introduce Dr. Dênis Bichuetti, and he's from the Federal University of Sao Paulo in Brazil. He's going to tell us about CRION and Lyon.
Okay, well, good evening everyone. Thank you for attending our session today. Thank you, Dr. Marie, for the excellent initial talk. We're going to spend the next 15 minutes on the interesting yet debatable topic of relapsing optic neuritis. There's a lot of information, so I'll try to hurry a little bit. These are my disclosures, as well as the disclosures for the group I work with. And here's a little introduction to our talk. I'll talk a little bit about some concepts and namings, briefly review the literature and discuss what's all out there, open you the preliminary results of our cohorts, have some words on treatment, and end with some final questions that are yet to be answered. So, once one starts to search on the topic in PubMed, you can find the matter of relapsing optic neuritis called by many names, sometimes referred as CRION, Lyon, or relapsing acute monophasic optic neuritis. CRION is used when a single episode happens to an individual without any signs of MS. MSON and NMOON is used to refer to the typical optic neuritis in each one of these situations. As we already know that in MS it's less severe than in NMO. For practical reasons, I will use the terms CRION and Lyon interchangeably in this talk to refer as patients with exclusive relapse on the optic nerves. I will also not talk on its differential diagnosis nor on the differences of ischemic to inflammatory optic neuritis, as assumed these are familiar topics to this audience. There are fairly some slides missing here. Okay, great. So, this is a summary of what's out there in the literature, or what I would consider the hallmark articles by each time it was published. Coppersmith was the first one to report on relapsing optic neuritis cases, and in 1988 he thought it was due to some sort of collagen vascular disease that had not the systemic syndrome blown up. Kidd was the first to use the term CRION and to report data on clinical, radiological, and treatment aspects of 15 patients. Furthermore, Perkel was the first one to associate relapsing optic neuritis cases to a final diagnosis of either NMO or MS. Still, in his series, there were some patients that kept on relapsing exclusively in the optic nerves. Some years later, after the discovery of the antibody NMO-IgG, Mattiello was the first one to report its prevalence on relapsing optic neuritis cases, and maybe its association to conversion to NMO on relapsing optic neuritis cases. Marinier found similar results on antibody positive in similar patients. Furthermore, until 2010, then Petzold and Yarius presented similar results on antibody positive and further explored its association to the development on NMO in patients that had only suffered optic neuritis so far. What is interesting in all this series is that you still have patients that are antibody negative that keep on relapsing exclusively in the optic nerves. We see that patients that are antibody positive have a higher possibility of developing the full clinical syndrome of NMO, and inside all these articles there is information on treatment of these patients with corticosteroids and or immunosuppression in order to avoid further relapses. So this is what we have so far until 2010. Relapsing inflammatory optic neuritis is a form of demyelinating or autoimmune disease that seems to have been interpreted differently in distinct time periods. that CRION or RION might be inserted in the context of an MO spectrum disorder, yet it seems lesser associated to an MO IgG as opposed to relapsing myelitis cases, as we know from the literature. If this is because aquaporin 4 expression is lesser in the optic nerves, if lesion length interferes in the titers of antibody, and you know, of course, the optic nerve is smaller structure than the medulla, the spinal cord. Actually, these are just two random questions that popped up my head. I don't know if these are the right questions or the right answers. So let me show you some data on our clinical cohort. In the past 18 years, we have seen nearly 1,200 patients with MS around 800 and MO 100, and then other neurological disorder. For this analysis, we have selected the 29 patients that presented the first 2 episodes as optic neuritis. That is, 2 optic neuritis 30 days apart before any other CNS clinical symptom. After a mean 8 years of follow-up, 10% of them were diagnosed as relapsing remitting MS, 30% NMO, and nearly 60% of them remained labeled as CRION. On disease onset, that is on first and second optic neuritis episode, demographic data was similar between all 3 groups. The rate of NMO IgG positivity in the patients that were tested seems similar than what was previously shown, and I must say that this is by indirect immunofluorescence. Patients with CRION seem to have a positive response to immunosuppression and steroids. That was the matter of a last year Ectrims presentation. And the most important information on this data is that the patients that ended up with the diagnosis of MS, they already had dissemination in space by McDonald 2005 criteria at the time of the second optic neuritis. What this tells us is that if you have a patient in the situation before any other symptom in the CNS with a normal MRI, you should consider autodiagnosis than MS, and possibly are candidates for early immunosuppression. I will talk about that later. I don't know why these are passing fast. We have also been looking at these patients by OCT. This is a transversal study we performed in the past 2 years involving 124 eyes of patients with relapsing remitting MS, NMO, and CRION. And for this analysis, I will only show the eyes of patients that have presented optic neuritis. There's more information on our poster tomorrow afternoon. There it is. And the table above, we can see the information on retinal nerve fiber layer thickness for all the 3 diseases. There seems to be a trend towards more severe damage to the retina in patients with CRION. We then did an exercise comparing each one of these diseases. So both populations of NMO and CRION had a more severe damage to the retinal nerve fiber layer than patients with MS. And patients with NMO and CRION did not present difference between each other. This is an interesting exercise that we did, plotting this data on a ROC curve. So using relapsing remitting MS as controls and NMO as subjects, we come out of this curve. We can point any of the data in this curve to see if we can have sensibility or specificity values that could tell us if that optic neuritis was in a patient with NMO or CRION. But we then pooled the patient with NMO and CRION together as subjects and still using relapsing remitting MS as controls. I apologize, I don't know why these are passing spontaneously. So I might be coming back in some slides. So this is a nicer curve that we can choose any value of this curve. What we came out with is a value of 41 micrometers that was 100% specific for NMO and CRION. That is, beyond this point, there was no multiple sclerosis ads. Of course, I do not intend to say that OCT should be used as a stringently diagnostic criteria, but rather invite other investigators to see if they can find similar results. Actually, there's a poster by the Charité group in the NMO session today that seems to have found values similar than ours. And also, this information is not intended to say if the both of diseases, NMO or CRION, are actually the same disease, but it says that they behave similarly regarding to retinal nerve fibrillary damage. What is out there about treatment? Well, prospective controlled studies might be very difficult to be performed, as this is an even rarer situation than MS. The steroids are mandatory either as post-therapy for relapses or orally for maintenance therapy, and immunosuppression seems adequate, whether you use as a thioprine, mycophenolate, rituximab, or IVIG. There are reports on the use of all these drugs in this situation, and it can be adapted to what is available at our country or center. Before we go to our last slide, let me present you these interesting cohorts from this year. I invite you all to read the original papers that are very dense and have lots of information. The first one is from a German collaboration group involving 175 patients with NMO spectrum disorders. Here you can have an idea of the prevalence of Lyon or CRION among this population. But most interesting is that the rate of antibody positive was higher than what described before. Maybe because they were treatment naive patients, maybe because they used different methodology for antibody assay. Furthermore, patients with optic neuritis that developed the full clinical of NMO, that is presented on myelitis, it took them a longer time to present the index event than patients that started on myelitis itself. Furthermore, there were patients that presented many episodes of optic neuritis before presenting myelitis, and some of them, in one of them actually, it took up to 30 years to present the index event. In the other series by the French group, this was the evaluation of 30 patients with the first episode of myelitis or optic neuritis. So I selected the 12 patients with optic neuritis, all of them with NMO-IgG positivity. In nearly 16 months, almost all of them presented a second relapse, and within 6 years described in the paper, one of them was deceased. So putting this together with the information presented in the past years, we can see how severe or disabling this can be to the patient. Let's go back a little bit. And how important it might be to select patients with this phenotype for early immunosuppression. What leads me to our final questions. Okay, so we present two at a time. What's in the name, after all? CRION, Lyon, CRION, relapsing acute optic neuritis. Is there really many differences between all these case reports, or are we all talking about relapsing optic neuritis related to the aquaporin 4 antibody? I think we're yet to be seeing a consensus approach in how we're going to call these patients, and if the antibody positive or antibody negative, as we talked before, should be approached differently. Is there any difference in relapsing cases, whether positive or negative for the antibody? Actually, it seems yes. And the series by the German group seems like the patients that were negative presented less severe relapses than the patients that were positive, and they took them a longer time to present with a myelitis, yet it happened. Should long-term treatment be offered to patients at the first episode of optic neuritis and positive results for the antibody? The answer would be definitely yes, because they have a chance of having a third episode or presenting a myelitis. But most important, maybe for the bedside physician, should treatment be postponed for patients that have suffered 2 episodes and are negative for the antibody? My answer would be no. These series that I have presented show that patients with 2 optic neuritis and negative antibody result will further present a third relapse or even a myelitis. So they are candidates for early immunosuppression as well, as long as they have no MRI signs of MS, of course. I further thank all the group I have been collaborated with, as well as researchers that have shared their opinion in order to make this presentation. Further thank you for staying with us and the committee for selecting me to talk. Thank you.
Thank you very much. Do we have any questions?
That's a very nice presentation. One of the questions that often comes up is whether we should test patients for aquaporin 4 antibodies after the first attack of optic neuritis, recognizing that the vast majority of people who present with their first event will be negative. Do you think that, or do you have data, or do you know of data that show convincingly that if you did OCT as a sort of stratification tool after the first attack, looking at attack severity, recovery, and OCT, that might allow you to select whom to test after the first event?
That's a tricky question. And
that's why I asked it.
Yeah. Maybe, I mean, if the patient is negative and the OCT values are very severe, like, well, something like 40 or 50 micrometer, we still wouldn't know if they simply had an idiopathic optic neuritis due to any viral source of anything else. I think this is an interesting information, maybe even more than the OCT at the episode, doing an OCT after a few months and try to see which patients, the grade of recovery, if it correlates to the antibody titer or positivity or no. But I'm not aware about if data about this question is published.
Questions there?
Mark Morrow from UCLA. I'd have to contest the idea that you suggested that in this condition. First of all, with optic neuritis treatment trial, we know that steroids don't make a long-term difference in visual outcome with optic neuritis. We're of course not talking about optic neuritis associated with NMO. Second of all, in the antibody-negative patients, we don't have anywhere near enough data to know what's going to happen with those patients. As a neuro-ophthalmologist, you see lots of patients who have 2 bouts of optic neuritis and nothing else, or go 10 years and have a third event. We really don't know what kind of immune suppression, if any, we should be putting these patients on. So the idea that long-term immune suppression is required in patients that have antibody-negative patients with 2 bouts of optic neuritis, I find that not at all based on any evidence.
I agree with you, and thank for the comments. Maybe because we are in a neurology clinic, we tend to see more of the patients that end up developing myelitis and are a bit afraid of that situation. Having 2 episodes of optic neuritis 30 days apart, in some of these series there were patients that still relapsed. Maybe it's up to a patient-physician decision or shared decision-making in order to select patients that would not receive treatment.
We'd hope that clinical guesswork is not part of the equation. And perhaps if you're talking about episodes 30 days apart, that's different than patients that have bouts, you said greater than 30 days, so a year apart, 2 years apart. Obviously, the longer interval, perhaps the more reassuring. But I think we're still certainly not at the point where we can recommend, based on an otherwise completely healthy patient with 2 bouts of optic neuritis and no antibody, that all of those patients require immune suppression.
Can we just have a quick question there, and then we must move on? Thank you.
Shamari from Kuwait. And the same theme of you have a patient who present with severe optic neuritis with negative NMO-IgG. But the visual loss is quite severe, almost complete visual loss. Do you still take the risk waiting for the second attack just because we don't have a clinical, research evidence?
I think that that's an easier decision. If you have a patient with only one episode or negative for the antibody, there's no evidence in the literature that you should go for immunosuppression. Maybe you could repeat the antibody later and see if it becomes positive or not. But in this situation, I would definitely not recommend immunosuppression.
Very good. Thank you very much.
Thank you.
Our final